Good morning. This is the Audit and Performance Committee of Perth and Kinross Integration Joint Board, Monday the 18th of September. Welcome. Could we start with any apologies or substitutes? Have we got any? Sorry.
We've had no formal apologies for the meeting this morning, but I've just been advised that Sandy Watts is having some issues trying to join, so hopefully she'll be able to join us soon.
I am in now, thank you very much.
Welcome, Sandy.
Thank you.
Okay, the first point is declarations of interest. Members are reminded of their obligation to declare any financial or non-financial interest which they may have in any item in this agenda in accordance with the Perth and Kinross Integration Joint Board Code of Conduct. Are there any declarations today, please? No. Well, that silence I will take. We'll move on now to the minutes. Sorry. Right, sorry, we'll move on to the minutes then. This is the minute of the hybrid meeting held on Monday, the 26th of June at 9:30 AM. Are there any points for correction, any additions or any points of interest or comments? Nope. Could I have a proposer and a seconder, please? Thank you, David. Do we have a seconder? Is there somebody online? You'll second, Sheila. Thank you. Okay, thank you for that. We'll then go on to the minutes of the meeting of the committee on Monday, the 31st of July. And there's only a few of us present, so could I have, oh no, I'll go through, sorry. Are there any comments for that meeting? It was a one item agenda. Nope. Could we have a proposal and a seconder? Thank you. Okay, that takes us on to the action points update. And is it yourself that's taking us through?
Thank you very much, Chair. There are three actions on the action log. The first one was a request for a one-off agenda item, stroke presentation on staffing issues, and there's a time scale suggested for that before the end of the year, so that would be December meeting. The second action 53 is the strategic risk improvement plan to be updated, and that has been complete as requested, and that was about changing the way in which it was presented. So hopefully you will see that in the papers today, that the improvement has been taken forward. And then the third one is 54, which is a meeting with chairs and officers to consider reassurance on risk processes. And I think there's been some movement on that from an NHST side perspective, but we will attempt to do that before the end of March 24. Thank you.
Okay, thank you for that. Are there any other matters arising in this section before we move on to performance? Okay, thank you very much. We'll move on to the performance section of the agenda. So 4.1 is our financial position, and we're going to hand over to Donna as Interim Chief Finance Officer. Thank you, Donna.
Thank you, Chair, and good morning, everyone. I plan just to do a brief summary of the report in order to leave some time for questions at the end. The report brings you the first financial projection for 2023-24, and members will recall that the IGB approved a budget for this year back in March, and using general reserves, the budget was approved as a balanced budget. This first, and what we also need to know early projection and report, is that there is an overspend above that planned position, and that's based on the expenditure to July this year. And the forecast overspend above plan is 2.465 million. Page 2 of the report highlights the main drivers of this additional expenditure above plan, and would note that firstly, the additional capacity within older people services, reflecting the increased pressures on the system since the start of the year, is one of the main drivers of this additional expenditure. The second being that there is an assumption at this stage that Perth and Kinross would continue to be attributed a share of the 2C practice costs within Dundee and Angus. However, since finalising this report, we do have 2 updates in regards to 2C. So the first is that we've made progress in our discussions to review the financial. Somebody wanted to come in there. No. We've made progress, sorry, in the discussions to review the financial risk sharing of primary care services. So that's primary care services as a whole, and the scope of that is currently with the chief officers for approval. But the proposal is also to start this review and due diligence process within general medical services budget. So that's the part that the 2C practices sit. And our proposal is to start the due diligence process with that, with the aim to coming back to this committee by the end of the year, which is December the 11th, I think the date is for the committee, with an update on that proposal. And our expectation is that we'll be looking for a formal outcome to be agreed before the year end. And our expectation is that that outcome will be favourable financially for Perth and Kinross. The second update to give around 2C is that regardless of the formal financial risk sharing amendment, the most recent projections that we've received after the completion of this report is that there is a reduced overspend and a reduced share towards Perth and Kinross. That's even before we've come to a formal agreement. So, and the third main driver of that overspend detailed within page 2 is within the out of hours service. It's led by Angus IGB. We understand that a financial recovery plan is being prepared to reduce the spend, and we've also asked for more detail on the service demands from a Perth and Kinross perspective. We'll update again at the next reporting. The other area that is not above plan, it's in line with what we expected when we were setting the budget, but another area that causes concern for the IGB and nationally for all IGBs and boards is the prescribing position. There's a national issue with the available data and that's on the actual spend and activity. Due to NSS, National Services Scotland, they've been working to deliver a new IT system, and due to significant technical issues in the go live phase, this has resulted in there being no actual prescribing data available after the 30th of April this year. So do recognise there's always a bit of a delay in us being able to get prescribing data, and we do always have to use a level of assumptions within our projections, but they're far higher level of assumptions that we're having to make due to the delay in this data. And as I say, it's a national issue, and our latest update is that we'll have more actuals available at our next monthly monitoring. But what that does mean is that the prescribing position is highly likely to change from what you have in this report. We have a date in the diary for October the 27th for a development session, and prescribing's on the agenda there, and the hope is that we'll look at this information in more detail at that time. The report recommends the committee notes actions that we're taking to mitigate the cost pressures, and these actions are primarily prioritising the review of the financial risk share on 2C and reviewing of the additional capacity currently within older people services, and that's to ensure we are achieving the best use of our resources with that. There are 3 appendices to the report, the first being the detail of the summary financial position, the second being more detail on the lead partner over and underspends, and the third being an update on our reserves. But I'm happy to finish there, just to take any questions on the report. Thank you.
Thank you, Donna. Mike, first question, if I can go first as the chair. You mentioned the review of the 2C practices. Who from our area is involved in that?
Apologies. The review is in two parts. So the first is to review the scope, and that will be with the chief officers to agree the proposals that are there. The second part is around due diligence, and that, if you remember, prior to the inception of IGB, was a big process that made sure that budgets were appropriate and that they were suitable, and that's an exercise. Somebody wanting to silence me. Yeah, the second part is to do a review on the due diligence. So that's going back to having a look at the budgets that sit within general medical services, of which 2C is a part of. What that will do is make us ensure, I think members have commented before, there's some overs and unders, areas that may be more favourable, areas that may be at detriment, and this process will allow us to flush all that out and give a proposal on our findings, and that would be led by the Chief Finance Officers. That part of the process would be.
I just wanted to make sure, because it was hosted, I've continual ask for reassurances from Hamish, for example, that he's completely involved in these kind of reviews, so there will be some clinical input to make sure the issues are all covered.
Very much so. Would seek Hamish's thoughts on anything that was being proposed, definitely.
Thank you. I'll throw it open. Are there any questions? Sheila McCall. Sheila.
Thank you, Chair. My question really is around the 2C practices. As I'm sure most people are well aware, in Perth and Kinross we've seen a succession of satellite GP surgeries closing, very often at short notice, and yet we have no benefit at all from 2C practices. I'm just wondering if it's how involved we are in terms of the overall strategy development for 2C practices, or if there even is a strategy.
Thank you very much for your question, Councillor McCall. There is the development of a whole primary care strategy, and we'll be involved in the discussions around that. I can just confirm to you that we have formally requested a review of the 2C financial risk share, and that's only just happened in the last week following a proposal that's come forward, so we will be carrying that out. But the adjustments that Donna as Chief Finance Officer has agreed with the other Chief Finance Officers will be applied from April 23.
Follow-ups? Yes, Sheila.
Thank you. So I think it's very welcome that the financial review is being undertaken, but I think it's because there's not clarity from me anyway, sitting on this particular board, of what the 2C strategy is. And I'm just wondering, Chair, if for this Audit and Performance Committee, because it does impact our performance locally in terms of GP services, whether it might be helpful to have some overview perhaps at a future meeting of this committee, or even the full IGB, on what the emerging strategy is for GP services and how that will benefit Perth and Kinross. Thank you.
I think that would be worthwhile, Councillor McCall, and I'm aware that just last week there was an appointment to the position of Director, Medical Director or Operational Medical Director for primary care services, so that would be something that we could probably engage with that new post holder when that's confirmed.
Thank you. I think that would be really helpful. It's certainly a very big consideration, and what's behind some of these questions, Chair, in particular. I'm sure the Perth and Kinross IGB members will know that we're about to enter the council into its budget setting process. So no doubt there would be some questions asked around the contribution that the council makes towards the IGB, because this is a very emotive subject for a lot of patients across Perth and Kinross. So I think the sooner we can address this particular issue and provide some clarity, I think would be extremely helpful to all concerned. Thank you.
Martin, you want to come in?
Thank you. Thanks for the report. I've a couple of questions, so I won't ask one and then let anybody else in before I ask the other. But the first question that I'm asking is in 3.25, and the out hours overspend is the result of changes to the patient pathway and the considerable increase in patient contact. Has that been identified as a new risk? Is it on the risk register? Because I worry, because in the previous paper it talked about the process, the risk processes. We'll have a look at that before the end of March. And I think we really need to be looking a lot quicker than the end of March next year and the processes, because we're starting to identify some of the risks here. So I'll leave that question. If you come back with other questions.
Thank you, Martin. In regards to the risk, so out of hours is both operationally and strategically managed by Angus IGB, so I would assume the risks are noted in their reporting. However, we will continue to flag up the financial risk around out of hours in our reporting. And as noted in my brief summary to introduce the report, we have asked for the information regarding from a Perth and Kinross perspective on the activity and the usage and any risks that are around for Perth and Kinross with an out of hours service.
Yeah.
Because that detail is not readily available for us at present.
Well, that's a way forward. I certainly welcome that, because if a risk is lying with one IGB that has impact on another IGB, then that should be a flag.
Yep. Okay.
Thank you, Martin. Since you've kindly offered, does anyone else have a question before we come back to your second? Nope. Right, Martin, do you want to give us your second question, please?
The one, and it's an observation first before the question, that the underspend and the overspend, it's obvious that every underspend is going to be calculated by having to bring in agency and staff, and there needs to be a reappraisal of the level of service and jobs that it provides, because that's just a taken that. And the passage above the underspend, the overspend, all on agency staff, but that's an aside. But the bit I've got on that, the Scottish Government have now stopped providing the drug that's comparable with methadone. Why has this been done? Are we still providing methadone? Or are we have to pick up the cost for that?
Thank you, Martin. In regards to the Buvidal, so the Buvidal was introduced as a policy from the Scottish Government during COVID, and we were asked to roll that out, and it was a replacement for some patients, for a replacement for methadone. During COVID, the Scottish Government provided funding to integration authorities to do that rollout. However, that funding ceased last year. We were temporarily allowed to use alcohol and drug partnership funding to offset the Buvidal costs. But this year, for 23-24, the expectation from the Scottish Government is that the costs are met within our own budgets. We've certainly nationally raised this a number of times with the Scottish Government and explained and shown them the cost pressure that's meaning for IGBs. And an update that I can give them, just a verbal update, that something that's came through since the finalisation of this report, is that the Scottish Government has provided us with the option to flexibly use any earmarked reserves that we have against system pressures, of which the Buvidal costs, I imagine, would come under. So we've made an application to the Scottish Government to have more flexible use around uncommitted earmarked reserves that are not yet committed financially this year. So there is a hope that we would get that approved and be able to partially offset some of the Buvidal costs in year. However, this does remain a recurring pressure for the IGB as the Buvidal is not funded by the Scottish Government. But I don't know if there's any other clinical information you need that I could refer to a colleague.
No, thanks for that information.
Okay, thank you, Martin. Any other questions in the room?
Beth, can I quickly make the observation that see whenever there's a new IT system being introduced, they should apply anxiety pills with it.
I'll take that forward for you, Martin, no problem. David, would you like to come in?
Thank you. While roughly £2.5 million is not a huge percentage of the turnover of the board, this is still quite a concern. And I know work's going to be done on the 2C and there's the delays on the prescribing data, but I am concerned at the choices we might have to make as a board to manage that overspend. Have you got any inkling or thoughts on what those decisions might be?
Thank you, David. At this stage, I would caveat the report with it is an early projection, and although we've gone through every area and made our best judgment on where we think that may end, the early projections are subject to change. So we wouldn't be proposing a rash change in our service delivery at this stage. However, as noted in the report, we have asked for older people, the additional capacity within older people services to be reviewed. This report only makes the assumption that these additional capacity measures will be in until the end of September. And a winter plan will come to the IGB, a Perth and Kinross HACP winter plan will come to the IGB in October. That will clearly identify the costs that would be incurred should it be approved. But we are making quite a detailed review of all the costs that are in the system to make sure we are making best use of our resources. Jackie, do you want?
And really just to add to that, to say that the management team have been working on, you've heard us talk about the re-establishment of a transformation board. So we're actually identifying 6 key areas of transformation, which will be absolutely critical for this, about maintaining our costs within budget, but also about creating greater efficiencies where that's possible. So we do need to bring forward information to the whole of the IGB around that transformation programme that's up and running.
Are you happy with that, David? The other thing that I was just going to touch on, and I think you alluded to it in an earlier answer, is the impact of the way we do things in one part to another. I'm just wondering, is there any potential that the review that they're doing within primary care will be the same kind of process within mental health, or is that something that's still taking a different route?
Thank you. I'm assuming that your questions around the reported overspend in inpatient mental health, and also the development of a recovery plan, and also how we support the funding of the or any additional funding that might be required to support the whole system change programme. We've had some very constructive discussions, Tayside-wide discussions around that, involving the 3 chief officers and representation from the Director of Finance from NHS Tayside late last month, and that will be taken forward in October. So we're feeling positive about the constructive whole system discussions that we're having there. And just to confirm that NHS Tayside do have a draft recovery plan in relation to inpatient mental health services that's been shared with us already.
Thank you, that's good to hear. Any other questions or any points people want to raise before we continue? Okay, so Sheila?
Thank you. Yes, excuse me. I'm just wondering if we have any position or any emerging position on a response to COVID, since there's a new variant. Not so far as I know in Scotland yet, or maybe it is, but just have we, what's our provision for that?
Financially, the Scottish Government have been quite clear that there is no additional funding coming forward for winter. They've confirmed that to us, and I would assume from that that means there's no additional funding for a COVID response at this stage. With nothing more.
Okay, thank you. Well, the recommendations are, it's recommended to the Audit and Performance Committee that we should note the overall project outturn for 23-24 based on financial performance the 31st of July 23. We should note the Chief Officer and Executive Management Team are working on actions to mitigate cost pressures in the current year, and we note the financial risks as detailed in Section 6. Are we all happy to note these? Okay, thank you very much. Moving on now, we're going on to the key strategic performance report. Chris, is that yourself that's going to take us through that?
Good morning, Audit Performance Committee. Thank you, Chair. This is a routine performance report providing the committee with an update covering Q1 of this financial year. The Audit Performance Committee is asked to note performance to date and note progress in the delivery of Strategic Commission and Plan aims. We have maintained our focus on the core set of integration indicators for which data is available at this stage of the year. We have had a change in our methodology for the gathering of data for these indicators, and that's largely down to the frequency of availability from Public Health Scotland. This means that comparisons to the peer group and to Scotland overall are more problematic and will come with a larger delay. Our new approach, however, does provide data which is more up to date than has been possible in the past. So turning to performance itself, key performance overview against the backdrop of significant demographic and workforce availability pressures. Performance has broadly improved from last reported. Delayed discharges in particular, which remain a key focus, have reduced by over 4% and at a faster rate than Tayside overall. This figure represents a reduction across the whole of the previous 12 months, however, and masks a significant and sharp fall in TDs seen since February of this year. That's detailed in Appendix 1.1. This has largely been achieved through a combination of increased investment in capacity, improvements in efficiency, greater integration of services, and notably the use of interim placements. If it's possible to sustain DDs at their current low rate, we would expect that 4% figure to grow significantly as we report throughout the rest of the year, given the sharp fall was only as a consequence, it has only occurred in the last 1 quarter. Moving on to emergency admissions, they've gone up marginally by 1.64%, but that is at a lower rate than Tayside. And Perth and Kinross continues to have a lower rate overall. Work in this area is centred on prevention and early intervention with community-based services development of models of care which seek to limit deterioration. Emergency bed days marginally down against Tayside. Over the past year, P&K rate has remained above that for Tayside, but the gap has closed over time with a sharp closing of the gap most recently. Again, detailed in Appendix 1.1. In respect to readmissions, 60 in the over 65 age group within 28 days, the indicator is broadly stable. There has, however, been an increasing trend when considering the all adult age group and most notably in respect to readmissions within 7 days. Work continues on breaking down the data here, and we had hoped to be able to report back to the committee progress in respect to that more fully, but it has proved to be a quite significant technical challenge to break down that data, and we will report back to the committee in due course with a more detailed update. So linking our performance to our delivery of strategic commissioning plan aims, we did that through the annual performance report, and we've carried that methodology into this Q1 report. Table 1 demonstrates that more than half of our KPIs at a care group level are currently green, and we remain relatively early stage in terms of the delivery of those strategic delivery plans. Finally, in respect to developments, as we continue to look to develop our performance reporting approach, we have committed to review our target setting approach to bring in targets which are more specifically related to Perth and Kinross, and so less so comparatively so with elsewhere in terms of the target. We will still provide comparisons, but the targets we would look to set would be pertinent to P&K. And we will also consider that in the context of a continued development of our whole health and social care partnership performance management framework, which builds on the development of the performance management frameworks for our strategic delivery plans. So we're happy to pause there and take any questions.
Okay, thank you for that. I know that this is a change in the way the data is presented, and I think that reflects the delay that I think also Donna was referring to. We've got one nationally with the prescribing, and we've been having sort of historical data analysis on these key indicators, so now they're local, so it's worth keeping that at the back of your mind. The one thing I was going to ask, and I mean, I think it's amazing to see what's been done with delayed discharges. I suppose the concern that I would have is that I know we're having a winter plan coming forward, but with lack of any additional funding, do we think that a lot of the difference has been to, you know, new initiatives such as our frailty teams, etc., and we're confident that we can try and maintain that through the winter, or?
Certainly happy to see to Jackie for a little bit more detail, but certainly in my liaison with service colleagues, the fairly targeted approach that you've referred to, connecting with our wider community-based approaches, we would make the assumption that those are making the impact that you've pointed out. Yes.
Thank you very much. I think really the answer to the question is it's not one single thing that's contributing to this. It's a whole host of improvement measures that have taken place, but I'm pleased that you have recognised the impact of that. There's a presentation to NHS Tayside executive leadership next Monday on this very topic. As you know, we report on delayed discharges very frequently, and it's not the only area of focus and concern, but I think the detail of the graphs that are presented here just show the significant work that has actually taken place and the impact of that. The key challenge is how we maintain it. It does remain fragile to some extent because we're now talking about very small numbers because we have our delayed discharges down to single figures. So if it's hovering around 8 or 9, that means that the whole system can flow, but it can easily increase from there, and we've seen that happen in the last few weeks where as a result of, for example, it may be a COVID outbreak, a small COVID outbreak would mean that people can't move on from hospital, or a significant small number, 4, 5, 6 of very complex admissions can affect the performance here. But I think presenting it in this way, you see overall the closing of the gap between Perth and Kinross and the rest of Tayside, and given our significant demographic and workforce challenges, I think it's a really just to commend everybody has had a part to play in this, because it's been a significant piece of work, resulting in significant better outcomes for our population.
Thank you, Jackie. I would. Oh, Kenny, do you want to come in, and then Martin online?
Thanks, Chris. Sorry, just on the back of what Jackie was saying as well. I mean, what we're concentrating on at the moment is making sure all our current resources are being used as effectively and as efficiently as possible. Due to primarily issues with recruitment, for example, to care at home and our enablement service, we've had to try and fill that gap with the use of, for example, agency workers, which are 70% more expensive than people that are actually salaried, and also the use of interim placement. So what we're doing is, we have got an effective recruitment programme in place. We are increasing our capacity across our internal and external care at home enablement services. And as we're doing that, we're cutting back on agency use and cutting back on interim use. So we're getting more bang for buck effectively. But, it will be a real challenge.
My only other question, sorry, Martin, I'll let you in next, is around the readmission rates. It's unfortunate that's so difficult because, you'd like the assurance that it's not as a result of our discharge that people are being readmitted very quickly. So I think it'd be I'll be looking forward to seeing some of that so we can make that comparator. Martin.
Thanks, Beth. You make a point that I was going to add, and the interim placement. Can you explain to me the process in your interim placement and how that's enabled? Because I have some difficulty sometimes with interim placement. People feel they're maybe being moved under pressure. And
Okay.
sometimes it just at least see people going back in quite quickly.
Okay, I'll hand that to Kenny.
I mean, certainly people who move to interim placements, they have their assessment carried out in hospital first. They're identified, the care that they require is identified, and the referral made for that care. Most of the people in interim placements are waiting on packages of care, but unfortunately we can't provide them immediately. So there are discussions with the person and their family, and they only move to an interim placement if they agree to move. And again, the advantage of interim placements is, it's a more homely setting to then go and wait for your package of care rather than be on a hospital ward. So again, ideally we'd be getting people straight home from hospital, and we've reduced the numbers down from sort of 40 to about 19. So like I say, there are robust processes in place. And discussions are carried out at an early stage with the people themselves and their families.
And if a family disagreed?
I mean, again, if a family disagreed, it would depend on the person's ability to make decisions for themselves. I mean, the person themselves said they were willing to go and they had capacity to make that decision, then again, they would probably move to the interim placement. But if they lack capacity and the family were disagreeing, then that shouldn't be the case without further discussion and potential legal action. And to be honest, by the time that takes, the care package should be ready and the person would move straight from hospital to their home.
Thank you very much. I was just going to add that this time last year, the expansion of the interim placements was actually a cornerstone of our response to the winter pressures across the whole system. But we're going into winter feeling much more in a much better position than we were last year. And as Kenny says, we've reduced the number of interim placements. It was up at the highest, it was at 43, and it's down to 19. So we've halved that, and we'll continue to reduce that. There will always be a number where that's absolutely the right thing to do, but we've reduced it considerably. So I think we're in a much stronger position, Martin, not to be in some of those really difficult conversations that you describe.
Thank you, Martin. Are you happy? No, you're coming
Now,
back.
just,
Hey, you're taking a lot of time up this morning, sir.
I
Come on,
just
on you go.
one thing on that. Have you refined and fast-tracked power of attorney and guardianship? Knowing how long guardianship can take and how costly it is for people.
We certainly try and process guardianship applications as quickly as possible, but there are two types. People can have the local authority acting as their welfare guardian, or families can pursue it themselves. And in terms of timescales where families pursue it themselves, a lot of that is actually out with our hands. We know we're relying on solicitor time, applications for legal aid can delay it, etc. But certainly in terms of situations where the local authority is acting as guardian, we do have processes in place to process that as quickly as possible, including the partnership funds, legal capacity as well, to make these processes as efficient as possible.
Thank you.
Thank you, Martin. I think I've reported previously that in Perth and Kinross, where we've got delays in relating to adults with incapacity and guardianship, they tend to be quite small numbers, and some relating to our psychiatry of old age wards and discharges from there. But I'm just looking today, for example, in terms of 9 delays in the acute side of things, where there's actually nobody in that, not one of those 9 people are delayed as a result of issues around guardianship. So I think that's a very positive picture.
Thank you, Jackie. You okay with that, Martin? Okay, can I bring Bernie in, please?
Hi, yes, thank you very much. Just following on from a couple of Martin's comments, and from Kenny. So I'm pleased to hear in relation to the interim placements that it is the families are involved and it is they agree to that placement. I'm not sure that that was always the case, but that's really positive. I suppose on that, I have a question in relation to families or loved ones that are transferred to an interim placement, that the funding for that placement is covered by the partnership regardless of the situation. I would like to obviously have clarification that that is the case, and that families don't find that their loved one is transferred to an interim placement and then it's at a cost to them. And my last point, actually, it was just on the fact of raising the power of attorney. Certainly, I know within Carers Voice, we have for a long time raised concerns about the power of attorney, and we seem to have some disparity within Perth and Kinross in power of attorney to other areas within Scotland. And I know that we've raised this with the partnership and that it's something to do with the wording, and we have tried to stress, can you please provide us with the wording that's acceptable to Perth and Kinross, but which again for me is a little bit difficult when it's acceptable in other areas across Scotland. And we've raised as Carers Voice that if there is change to the wording, and exactly as Martin has raised about costs to family, there will be hundreds of families out there, and I would actually include myself in that, that have a power of attorney document in place, and I'm assuming that my power of attorney would be fit for purpose within Perth and Kinross, but I'm not clear that that's the case, and my family could end up in a situation in relation to the change. So I'm sorry it's a bit off target for today, but it was just the fact that it was raised, and I'm not sure if you're aware of that, but that certainly is a concern for us in Carers Voice within P&K. Thank you.
Thank you, Bernie. That's an interesting point. I've never heard that before, but I'll hand you over to Dawn initially to talk about the cost.
Thanks, Bernie. Just on the first point, I would state that anyone that's in an interim placement whilst they're awaiting housing or care at home, they are not charged for that placement. However, should their situation change and then they're assessed as best best requiring permanent care, for example, then yeah, the situation would change. But whilst they're in an interim placement, no, the family are not charged.
Thank you, Joanna. Is there anybody could comment on the power of attorney issue, Kenny?
Yeah, I think the issues you're referring to, Bernie, if there's a deprivation of liberty when the person's moving to a nursing home that's a locked doors policy. We have had ongoing discussions with our legal department, and I know there are concerns with the wording in some of the welfare power of attorneys whether it is a deprivation of liberty. What I can do is get in touch with our legal department and get in touch with you out with this meeting.
That would be great, Kenny. Thank you. As I know, it certainly is an issue that has come up time and time again within Carers Voice, and we don't ever seem to have had an answer to it. But what you've said is exactly what it is. It's in relation to deprivation of liberty. Thank you.
Okay, thank you, Bernie. Can we move over to Sheila McCall, please?
Thank you, Chair. My question really is in Appendix 1, the first graph. I first of all want to say that the hospital to home initiative has had some very favourable feedback that I've had from one or two constituents. So I think it would be interesting to know what impact that's actually having more directly and what the expansion plans might be. One thing I'm curious about is about the increase in emergency admissions. And I'm wondering, have we any evidence or data that people are being going to the emergency department because they've not been able to see a GP, or because they've felt they wouldn't get a GP service quick enough? Because I think that's a recurring commentary, anecdotal although it is, from constituents, and sometimes they're not always admitted, but they're attending emergency services for things that perhaps in other circumstances might have been attended to by a GP. So anything in terms of that? Thank you.
I'm not sure who could answer that. Chris, do you want to come in?
Yes, thanks, Councillor McCall, for the question. So, specifically in reference to emergency admissions, that data is not affected by attendances at A&E, which may be driven by your suggestion of difficulty in getting GP appointments, but this specifically relates to admission at that point. So that would be a clinical decision that's made at that point, and that person requires to be admitted. On the kind of wider point, I think the first chart in Appendix 1.1 illustrates the lower, albeit increasing, but lower rate of emergency admissions that exists within Perth and Kinross than across the wider Tayside. And given the demographic pressures that exist within Perth and Kinross, the already higher number of elderly population, you may reasonably expect a greater number of emergency admissions with that cohort of population. There's probably not a lot more I can say about that in respect to GP appointment access just at this time. So.
Okay, Sheila.
Councillor McCall, I was just going to pick up your comments on hospital at home, because it's a relatively new service. It's really only become fully operational in the middle of last month, so I think we need to recognise that. But we're having discussions about how will we present that alongside this data, because we need to see that too in terms of what does that mean in terms of preventing admissions to hospital. But we need to recognise that actually those are people who are requiring medical treatment within their own home. So we will require to update our reporting to you to take account of that. So we're considering that currently.
I'll just make a comment really, Chris, thank you for that answer. I know it's not an easy one, but I do know, like I said, anecdotally from constituents that, on occasion people have said, oh, well, they didn't even bother trying to get a GP appointment and they left it too late and they went to A&E and then they had to stay in hospital. So I'm just wondering if there maybe could have been an element of prevention had they felt more confident. Right now, there's a very low level of confidence, even in the city, about accessing GP services or even being able to see a GP. So I think I'm concerned with the closures of our GP satellite surgeries around the whole of Perth and Kinross, where many of our elderly patients do indeed live as well, particularly in rural communities. So it's maybe something to keep an eye on going forward and to see if there's any cause and effect there. Thank you very much.
I'm not sure we'd be in a position to actually give you any clear answer to that today, but I think it's something that we come back with giving some reassurance around that in terms of the relationship between GP attendances or avoidance of GP attendance and what that might mean at the hospital front door.
I don't think it's avoidance. I think it's just they either phone and they can't get an appointment or they can't see a GP, and particularly for elderly patients, you know, they like to actually see their GP rather than just talk to somebody over the phone, because sometimes it's more difficult to describe and they just think, oh, I'll not bother them, too busy. So I don't have a sense of whether or not there's a big issue here, but I do know it's an emerging narrative that I'm hearing. I don't know about David, but I'm certainly hearing that.
Sorry to come back in this because I think it's a conversation worth looking at in a bit more detail, because we also need to factor in the out of hours service and the increase in terms of the workload that's happening there, so that we've got that whole picture. So in the same way that we said we need to bring back some more information around primary care and the strategic or the strategy around that for Tayside, I think we need to think about out of hours care as well, because that's something that's we've seen increase and we've seen the costs increase as well.
Okay, thank you. I think the discussion's been very welcome, and I think it shows you a lot of the initiatives that are being introduced around this particular area. And I think it's going to be a really interesting winter to be able to look at the differences this winter from last winter with the different initiatives that we've brought in. Okay, the committee have been asked to note the strategic performance in relation to the core suite of integration indicators and to note progress made in the delivery of strategic aims through SDP outcomes. Are we all happy with that? Thank you very much. We'll move on to the governance and assurance section now. And the first item is strategic risk management update. And I think that's Chris again. Thank you.
Thanks, Chair. So this report provides an update on the IGB Strategic Risk Register and the improvement action has been taken to improve the control environment, emerging risks and any material changes to existing risks. Following the most recent review of the register, we have committed to undertake a full review of all the risks to ensure that that we're content that they adequately reflect the risk environment. Some of them have been on the register for some time, and a lot may have changed in between times. As part of that, we'll also consider alternative approaches in respect to the setting out of our risks and specifically our improvement actions, and we'll reflect on the approaches taken by our colleagues in our partners across Tayside as we bring that forward in the future. The committee will know we have 9 strategic risks currently on the strategic risk register. Recent review of these resulted in a couple of changes. So SR04, sustainable capacity and flow, the description of that risk has changed, and I referred to my previous comment about a changing environment, and so that risk description has changed to reflect that. That same risk, SR04, has also had the probability reduced to 3 from 4, meaning the overall score is now 15, and that makes that an amber risk as opposed to a red risk. And thirdly, strategic risk 08, widening health inequalities. The risk description has also been changed to better reflect the current exposure. There are no other movements in risk scores at this time. In bringing this report together, operational risks held by partner bodies have been reviewed and no new risks of a strategic nature have been identified. There has, however, been development work in respect to the mental health whole system change risk, where our Chief Officer hosted a Pan Tayside workshop, and we, with colleagues across Tayside, produced a risk description which is contained within the report today. And the intention would be that that risk would make its way onto our strategic risk register, and that of each of our Tayside partner bodies, it being by its very nature a whole system risk. Table 2 within the report shows the IGB current and previous risk exposure, which has improved over the last quarter. Assisting with this is progress made in implementation of improvement actions set out in Table 3 and Appendix 3. And we have made some changes, as Chief Officer indicated at the start of today's meeting, in respect to how that improvement plan is laid out, particularly with the inclusion of a date action added and a revised completion date, which I think Councillor Wilco specifically mentioned and was discussed at the last committee. But I think it would be fair to say that's the first iterations that we would look to change, and I think, as I mentioned a moment or two ago, we will reflect on how that's done elsewhere, and we'll continue to adapt as we move forward. Just happy to pause there.
Thank you, Chris. Are there any questions, comments? David?
Yeah, given the content of the first report we had today about financial update, is it appropriate to leave financial risks as priority 2?
Sorry.
Thank you, David. And yes, it's a good question, and one that we considered before finalising the report. The strategic risk is noted to say that there are insufficient financial resources to deliver the objectives of the strategic plan. And for this financial year, for 23-24, the IGB approved a budget that was going to protect that ambition. And we're not, as I said in response to one of your earlier questions, we're not moving away from that at this stage. We collectively agreed that to increase this risk on the back of the first financial projection wouldn't be prudent, and to hold that if there's going to be any change, it would come to the Audit and Performance Committee in December. Once we've had, by that time, ideally, we'll have looked at month 7 reports and have a far better idea if the risk needs to be amended.
Okay, thank you. Are there any other questions, Sheila?
Thank you. For my sins, I also sit on the NHS Tayside Audit and Risk Committee. And one of the discussions we've been having is about where risk should sit and which risk register, particularly where there is perhaps one of the IGBs is the lead partner for a particular service area. And I'm just wondering whether or not there is work going on to see how at least the component parts of the 3 IGBs plus the Tayside Health Board can ensure that some risk isn't being hidden from, not deliberately, but just as not as transparent as it could be, not just financial but also operational, between one and the other. I know it's quite a bit of a debate, and internal audit has had views that have been taken on board in Audit Scotland. So I just think there's a possible risk, if I can use that word, that there something may be missed for Perth and Kinross if it's been led by somebody else and it's on their risk register but we're not seeing it, or equally that something's at risk in an IGB that, or sorry, in a health and social care partnership that NHS Tayside isn't seeing. So it's how do we join those dots, I suppose, or at least do those pointers. Thank you.
I'll begin the answer, and I can see Chris wants to add to come forward as well. But I suppose it's important to recognise that there is a strategic risk management group that meets bi-monthly, I think it is, every 2 months. And at that there will be a presentation and a report from each of the IGBs in relation to their strategic risks and anything that's coming through operationally. And that's shared with all of NHS Tayside members of the Strategic Risk Management Group, where there's a review of the strategic risk for NHS Tayside. So that's, I would suggest, is the forum where the discussion would take place to ensure that that doesn't happen. I think one of the issues that's in my tenure has been where the lead partner arrangement sits with the chief officers around primary care and mental health. That's the confusion. So it's less about the IGB's risk and much more about the lead partner's role in the management and the ownership of that risk.
I think that really is where the discussion was heading, because ultimately it's all part of the NHS, those particular services. It's why I didn't necessarily include local authorities, although there maybe is a part of that as I'm part of the partnership. I used the IGB incorrectly. I meant the Health and Social Care Partnership, obviously. But I do think that's still an open issue that probably needs to be resolved, because there are lead partners for some of the services that we may expect to come, and if they don't come or there's something going wrong, they may have both financial and operational issues. So I just think I'd like perhaps to keep a watching brief on that one, perhaps, Jackie, and just make sure that there's nothing untoward. And if something does come forward from the strategic risks management group, that it could perhaps be included even as an appendix to this report as well, just for awareness if nothing else. Thank you.
Okay, thank you. I can't see the screen, but is there anybody online that has any questions? Is there any way we can see the screen? Yes. Nope. Thank you. No questions? No comments? Okay, well, we've been asked to approve the IGB Strategic Risk Register and Strategic Risk Improvement Plan. Are we approving this paper? Okay, thank you very much. Right, we're now going on to the Partnership Improvement Plan. Who's taking that one forward? Well, thank you.
Thanks, Chair. Good morning, everyone. The report today provides the Audit Performance Committee with details on progress towards achievement of our actions within the Partnership Improvement Plan. The plan itself is attached to today's report at Appendix 1. So, since the Partnership Improvement Plan was last presented to the committee back in March, 2 audit assignments have been completed and both been presented here. These relate to sustainability of primary care services, and we had our internal audit. A reminder that any accepted recommendations from our audits then form new actions within the Partnership Improvement. There was no recommendations for P&K from the primary care audit, and there's no recommendations associated with the annual internal audit. The annual internal audit report, a reminder that the Chief Internal Auditor stated in her annual report in June that reasonable reliance can be placed on the IGB's risk management and governance arrangements and systems of internal control, subject to management implementation of the agreed actions detailed in the annual audit reports. The PIP is our mechanism where implementation of the agreed actions takes place. The improvement plan today does contain 17 new actions, though, since last reported here in March. These 17 areas to further strengthen the governance arrangements were identified in our annual governance statement, which was approved here at committee in June this year. All of these actions have now been incorporated into the plan, and it should be noted that we have already completed 4 of these actions. 5 actions in the plan today at Appendix 1 are marked at red rag status. However, this should actually be 4. IP40 in the financial control section has also been completed, so apologies for that. That should be blue complete. The budget was set in line with reserve policy, so we've already made that improvement. Regarding the remaining 4 red actions, officers are confident that many of these will be able to be progressed in the next iteration of this report. And just to conclude, we should note the significant progress which has been made against the Partnership Improvement Plan. I won't go through all the completed actions, but members will be able to refer to section 3.5 in today's report, which is on page 57 of the papers, which details the 10 or 11, 10 actions, but we've got that one I referred to earlier, which have been fully implemented since last reported here to committee. These 11 actions which are completed will now be moved from the plan into our completed database, and we will refer to those again when we complete our annual governance statement next year. Those will provide evidence of our governance improvement actions. Happy to pause there and take any questions.
Okay, thank you. Any questions? David, do you thought you were?
Sorry. The red, amber, green classification of risks includes blue. I'm not sure what blue means.
Yeah, thank you for that, Councillor Illingworth. You're absolutely correct. We should probably change the title of that to just status. Have the key at the top. So you're right. Yeah. Blue is completed. Yes.
Thank you. Any other questions online? Okay, thank you. Can I just quickly ask about the Transformation Board, which has been re-established and meets regularly? Can you just give us some assurance that that is working in collaboration with the Transformation Board within our partners to make sure that we're not working in complete isolation in our transformation work?
Thank you. Yes, I'm pleased to say that we've expanded the membership of the Transformation Board to include representation from NHST side and Perth and Kinross Council. And we, as a partnership, presented to Perth and Kinross Council's Transformation Board itself. And I think that was just over a week ago, not quite 2 weeks ago. 2 weeks ago tomorrow, I think it was, and we will be giving some insight into our transformation to NHST side's ELT on the 25th of September as well. So I think we're trying to make as much connections there as possible, because you're quite right in terms of care at home, for example, and the importance of recognising where the third sector and the community response is as important as the services that we are responsible for in terms of strategic direction from the IJB. Thank you.
Thank you. No, the other question I had, it was good to hear that we've got our Associate Director for Primary Care. I was just curious about the Chief Social Worker role. You were hopeful by the end of September. Is that looking likely?
In answer to that question, the Chief Social Work Officer role has been incorporated into a new strategic lead position within Perth and Kinross Council, and that's a strategic lead for children, families and justice. And the interviews will be held before the end of this month, so recruitment is underway.
Thank you very much, Jackie. Sheila?
Thank you, Chair. My question really is just around the sustainability of primary care services and the recommendations. I know it resides with Angus IJB, but we last seen an update on that in March, and I'm just wondering when we might see a further update here.
So you want to do that? That's my fault.
Thank you, Councillor McCall. I was considering that, and the Partnership Improvement Plan, although there's no direct recommendations for P&K IGB in there, they're all the responsibility of the Chief Officer of Angus IGB. We should be perhaps providing the committee here with assurance on how those recommendations are progressing. So perhaps there's another section at the bottom of the report that we could consider with this one and anything else that comes up that might be in other audits where P&K are indirectly concerned with it. So something I'll consider putting at the bottom of the report to provide that level of assurance that the committee members should probably see.
Thank you. I wasn't looking for a massive big report because I know everybody's workload is particularly onerous. But I think it might be helpful, particularly in those services where there's a lot of concern locally and that have been adversely impacted. It's not casting any doubt whatsoever, please be assured, on the performance or the work that's been done in either of the other two health and social care partnerships. I'm very well aware of how diligently they're working and how they're moving towards a solution for the whole of Tayside. But I think for this specific IJB and this health and social care partnership, and certainly, so I'm sure David's nodding along with me here, you know, the citizens of Perth and Kinross specifically would be helpful to have, you know, like so maybe just a brief update on where some of these things are and what the impact might be. Thank you very much.
Okay, thank you for that. So we're asked to note the progress towards achievement of actions within the Partnership Improvement Plan. Are we happy to note these actions? Okay, thank you. Thank you. Right, we're moving on to the clinical care governance section. Clinical and care governance assurance. Taking us through this. Sorry, Kenny. Over to you, Kenny.
Thank you, Chair. The purpose of this report is to provide assurance to the Perth and Kinross Health and Social Care Partnerships Audit and Performance Committee in respect of clinical care and professional governance arrangements in place for delegated and lead partner services managed by Perth and Kinross Health and Social Care Partnership. And in the appendix of this report is a copy of the report that was taken to the NHS Tayside's Care Governance Committee and Perth and Kinross Council Scrutiny and Performance Committee. And the timescale for the data in the report is from 1st of March 2023 to the 30th of June 2023. And again, just the report contains updates on exceptions previously reported relating to social work staffing capacity at the Integrated Discharge Hub, and also the use of agency staff to fill nursing vacancies, and both situations are improving. The report also contains updates on the red risks or the red operational risks faced by the Health and Social Care Partnership relating to accommodation, mental health workforce, GP cover at HMP Perth, mental health waiting times in HMP Perth, capacity and flow for older people, inadequate environment for the CCATs in Perth City, care home capacity, OT capacity for assessments for OT aids and adaptations, social work capacity in the Kinross team and primary care services. It's also a summary of adverse events, and most of them are minor or negligible. None of them are outstanding on DATIX, and the main themes are slips, trips and falls, medication issues, clinical and challenging behaviour, violence and aggression, and pressure ulcers. Also a summary of complaints. And the main themes are waiting times or delays, staff conduct, disagreement with assessment, quality of care. During this time frame, there were external inspections at our older people mental health wards at Murray Royal. That was Gary, Tummel and Leven. And again, overall, the inspectors were impressed by the standard of care. There were a number of recommendations made and action plans are being implemented to address them. Also an update on the implementation of medication assisted treatment standards in Perth and Kinross. And just a summary at the end regarding ongoing risks relating to workforce, which cut across a lot of the red risks that I previously mentioned. I think it's important to note, I know Chair Yoka, you'll come to the notes as well, but just in addition, the third note down mentions that NHS Tayside's Care Governance Committee accepted that substantial assurance had been demonstrated by this report. And since this report was written, Perth and Kinross Council Scrutiny and Performance Committee also agreed that substantial assurance was demonstrated when they met on the 13th of September. Thank you.
Thank you for that. Maybe before we continue, just there was a question about my ability to chair the Care Governance Committee and this committee. I have received advice from the Board Secretary at NHS Tayside that it's completely okay, that I am sitting on this board in a completely different role from that in NHS Tayside as well. So I will just take the Perth and Kinross issues at Care Governance as normal. But it's worth noting that in the minutes that there is no objection and there's no reason why I can't chair both. So just to let that in. Any questions?
Thank you. One of the things that sort of jumps out is wait time for hand therapy being over 3 years. Is it a huge? Is it hundreds of thousands of patients or 5 patients or any update on that situation?
I think the exact figure, I think it's into 83. There you are. Thank you. My my chief officer has just said 83, and it's due to a combination of factors. There's been changes in consultant behaviour in terms of more operations being completed. There's increased demand just due to population issues, but we can say our paper was taken to our EMT last week, and we have approved fixed term funding to address the backlog. So action is being taken to reduce that.
Great, thank you.
Martin, you want to come in?
Thanks, Chair. Thank you. When we look at the risk mental health waiting times within the prison healthcare service and also mental health waiting times, yet again, see no acceptance that addiction is part of mental health. 53% of people who have mental health problems have addiction problems. But it seems to be separated yet again. But when are we ever going to actually have something that's actually looking at the whole problem instead of putting it into silos?
I mean, certainly it's separated in terms of waiting times, just in relation to the reporting arrangements for this committee and other committees. But certainly on the ground, there is ongoing work locally, nationally and regionally to pull together substance use and mental health services, and that there's a lot of work going on in Perth and Kinross at this moment in time. I think, as we said before, we now have a service manager who has responsibility for the mental health teams and for the substance use service, and there's work going on the ground with those teams to improve the integrated working across Perth and Kinross. So yeah, I mean, there has been a lot of progress. There's a lot of work still to do, but just want to try and provide reassurance that certainly on the ground that work is progressing.
Are you happy with that, Martin?
I just have to accept that. I'm never going to be happy till it becomes a norm, kind of opposed to. And I know that there is work being done, but until there's some recognition that then we're always just got to be throwing good money after bad, and because we'll never get a solution. We're always trying to stay in the problem.
And thanks for pursuing what is a very important matter, Martin. And you'll know that one of the areas of redesign within the whole system change programme is around an integrated approach to supporting people with mental ill health and substance use challenges. And I think the challenge that you're giving us here is how we're going to report on the impact of that in an integrated way. I don't have the answer yet, but I'll certainly take that back into the conversations that we're having across Teesside.
Thanks for doing that.
Okay, thank you, Martin. Sheila, you want to come in?
Thank you. I think in terms of Perth and Kinross specifically, where we have 2 prisons, I think Martin raises a very valid point, and I do know that the Community Justice and Safety Partnership does work with the prison. Looking to Martin, who's over the prison service, and with the police, because he's absolutely correct that very often, people are remanded when in fact the root cause is perhaps substance abuse or indeed mental health issues. So I'm not sure how that would be reflected in the clinical care governance report, but it's maybe worthwhile getting some narrative from the community justice team around some of that, because it is a bit of a gap, I think. And also you have in here a risk, it is a risk that there's that recruitment to the hospital at the prison, for any of us who were on the visit there, but again, through the Community Justice and Safety Partnership, we know it's a challenge. So I'm intrigued on risk 1226, GP cover for HMP Prison Perth. 11 new GPs now available. Where do we find the new GPs from? And are they just for the prison?
They're supporting the prison on a locum basis, so it's GPs that have other jobs, so to speak, and they've been attracted to the prison by enhanced rates that we're offering to increase the capacity in the prison, which should be a short-term fix while we're working on our longer-term model. I think we are hopeful of attracting one salary GP, and also looking at enhancing the use of advanced nurse practitioners.
Just want to come back in briefly. Thank you, that's really helpful. I suddenly thought there's a whole flurry of GPs had landed in Perth and Kinross. I'm going, great, let's have them. But I think, again, just to go back again, we talk a lot about reacting to, you know, when people present to GPs or to hospitals. But in this particular case, particularly around mental health and substance abuse, I think prevention is a huge area that perhaps we need to consider how we can make that effective, so that people don't end up in either the justice system or indeed in the health system, if there can be preventative actions taken a bit more. Because very often people who end up in the justice system is as a consequence of perhaps health failings, either self-inflicted or otherwise. Thank you.
Okay, thank you for that. Any other thoughts, Jackie?
If there's no other questions, as I was preparing for this morning, I was thinking that in the same way that we provide a table or an appendix in other reports, I think it would be helpful to have a table that sets out when the clinical and care governance report is reported to the NHS Tayside Care Governance Committee and the Council's Scrutiny and Performance Committee, and the outcome of those meetings, so that we've actually got that over the calendar of the year and we can see that at a glance. I think that would be helpful, given just some of the discussions that we've just had in terms of levels of assurance, and that will show how that's being maintained, or if there's any changes there, and it allows the committee to interrogate that a bit further.
Thank you. Just as Kenny would expect, just to comment on the substantial assurance. It was, I would confirm, a detailed discussion. It wasn't actually around Perth and Kinross, to be honest. It was around Angus, and there was some strong feelings on the committee from some of the lead officers around whether it was substantial or not. And I think, as we agreed, it was substantial. We agreed Perth and Kinross were. I think the debate continues, and there's some discussion around how we identify the level of assurance. And there's the argument it's about the process, not the outcomes. And if it's a process, it's substantial, but there's some concern about how can we know about outcomes, etc. So I think there's going to be further work around these categories and how we get our assurance, particularly in relation to other committees and how they get their assurance. So, but it does reflect well on Perth and Kinross that they were, under the current conditions, getting that substantial assurance. So well done. Pass that on to all staff involved, and all those in the third sector and carers, etc., that are part of that environment. The one thing I'm always asking, and I know it's, it's repetitive, but I'm always interested with this intensive work on not having agency staff. How are we doing? Is that having an impact on our ability to deliver good quality clinical care?
Yeah, I mean, basically, we are having an impact. We are significantly reducing the use of agency staff, and that in itself improves the quality of care, you know, because you're getting consistency in terms of staffing groups, staffing teams, people that are face-to-face supporting patients and clients.
And just to add that given the recruitment challenges and the geographical challenges, there is an exception granted for prisoner healthcare, and I think that's probably national and local recognition of the challenges of recruiting to all professional roles within the prison. So we have an exception there that allowing us to block book agency staff with the appropriate experience and qualifications. And also there's an exception in relation to our community hospitals, because it's not where there may be unanticipated absence due to sickness or for other reasons. It's not possible to move people around the community hospitals because of the geographical spread, and it's quite different to operating an acute hospital where you can move staff around and offer additional shifts in that way. So we in Perth and Kinross, I think we are seeing that the community hospitals are escalating requests for agency staff, and we also have a particular demand in the prison that we're managing that. So yes, I think we probably as a locality and as a Health and Social Care Partnership are one of the highest escalators for agency staff. Yes, that would be the first port of call. Yeah.
Thank you. It's just anecdotally to use Sheila's phrase, I've heard that it's been successful in the sense that a lot of staff that left the NHS to work for agencies have come back into the NHS because there's not enough shifts out in the agency. So I think that in itself is good news, but it's just always that worry during that period that we do have the staff. So thank you for that. Are there any other final points or questions that anybody wants to make? Sheila? Yeah, I thought that was your hand up. Nope. Okay, well, we have recommendations. There are 4 of them. First is to note the responsibilities of Perth and Kinross Integration Joint Board in respect of clinical care and professional governance, and those of the NHS side and Perth and Kinross Council. To note the arrangements in place for providing the IGB with assurance that effective and robust systems of clinical care and professional governance are in place for integrated health and social care. To note that NHS Tayside's Care Governance Committee agreed that the most recent report presented to them in August 23 demonstrated substantial assurance, and to note that the Chief Officer confirms the effectiveness of the above systems in place in the Health and Social Care Partnership, reporting to both NHS Tayside and Perth and Kinross Council governance and quality assurance arrangements. Are we all happy to note those? Okay, thank you very much. So we're moving on for information. The Audit and Performance Committee work plan. Who's going to take us through that? Anything? Any questions on the work plan? Go for it, Sheila.
Thank you. It's really around the premises and property that's coming to the next committee. I take it that's aligned with some of the work that's going on currently with Perth and Kinross Council.
Yeah, thanks. I can confirm that that internal audit activity is underway at present and will take account of the Health and Social Care Partnership's engagement with the developments across both of our parent bodies. Yeah.
Thank you. Is there anybody for audit here? No.
No, Jackie Clark's attending at the next meeting to bring these forward. I think Jackie's on leave this week.
Okay, well, we'll note the plan and we'll note that we'll get some assurances at the next meeting. Have we any progress that we are aware of? Any progress reports are coming through yet?
Yep, Jackie's made us aware that she'll be bringing the reports to the next meeting. I don't think there's going to be any delays in any of the reports that are identified on the work plan. Sorry, I'm just looking at Phil for confirmation of that.
Yeah, the Chief Internal Auditor has confirmed that she will be bringing the progress report on all the audits outstanding, as well as the plan for this financial year, and those 3 audits that are contained in the work plan will be brought forward. That's the latest information that I have.
Okay, thank you. Well, Sheila?
Thanks. I note that the performance and the financial position won't be brought forward to the next meeting. Given that there's significant challenges everywhere, and that some in preparation for, you know, the whole budget setting process, both here and in the council and indeed in the NHS, I'm just wondering whether or not there's something we maybe need to do offline around performance, financial performance, just to have something that we can be a bit better, not better prepared, but something that we can explore a bit further what the situation is. I'm not suggesting it comes to the next meeting because it'll be a full agenda, but I'm a bit concerned if we leave it until December before we start having a conversation about financial performance. It's cutting it a bit fine in terms of the budget setting processes for all the organisations.
Thank you. Yes, the October meeting is an additional meeting. It was originally just the first one item agenda for our annual accounts. We have been looking at IGB budget development session dates, and I think the first one that was proposed was to be the end of November or December, so we could look at them again to see if it would be worthwhile bringing it forward. As you know, we would want to use that time as valuable as possible for the most value, and the preparation and getting enough information together for you to then make a decision on might be the challenge, but we can look at that.
I suppose what I'm really getting at as well is that we understand the timetables of our parent bodies and try and make sure that we're at least somehow aligned or mindful of when those are, because I think all of the councils across the whole of Tayside and indeed the NHS are all facing challenging financial situations, so it's possibly a little bit more complex. Maybe even it's just to understand all of the issues and what the options are might be helpful. That's all.
Might be worthwhile us sharing the budget timetable with you. We've got a meeting this week with the Chief Accountant at Perth and Kinross Council to ensure that we are dovetailing with all the key dates, and that is something we would do anyway, but it might be worth us sharing it with you so you can see what the key points are.
Okay. Any other points, questions? Nope. That just takes us to the Audit and Performance Committee record of attendance. You can just check if there's any anomalies or something wrong with that, you can let us know. And the last point on the agenda is a private discussion, but as Audit aren't here, I don't suppose there's any point in us having a meeting with the auditors. So the date of the next meeting is Monday, the 30th of October 2023, and I'm assuming again it'll be a hybrid meeting with the main body in the council chambers. So thank you very much for your attendance and your interest and questions. Thank you very much.